All right, so with that then, I've gotten the blessing from Dr. D'Angelo to introduce myself. So I will introduce myself. My name is Bob Gaiser. I'm a professor and chair of anesthesia at the University of Kentucky, which is a little bit of change. So here's my UK tie, and I've slowly become a basketball fan. The person who will follow me will be, I think, Dr. Scavone. Do you follow me, Barbara? Who will be talking about maternal morbidity and mortality, and then Dr. D'Angelo will finish up this panel, and then as well as manage the questions. So what I'm going to do is I'm going to talk a little bit about Zika virus. I do have one thing to disclose. I must disclose that I do get reimbursed from the ABA, and it's not me. The ABA pays my department for my time because I am a director for the ABA, so they do pay for part of my time to my department. But we're going to take a look at some of the viruses because it really is a big issue now in anesthesia, and you're going to hear about this because I'm going to bring some stuff that's very recent and some old stuff, and it's going to challenge the way you think or approach these patients that have these infections. So we're going to look at Zika infection. We're going to get a chance to look at the Herpes Simplex virus as well as the human immunodeficiency or HIV. We're going to come up with a plan. We're going to figure out how we're going to manage these patients that do have these infections. We're going to take a look at transfusion protocols and as well as adjust preoperative assessment based on the infection with HSV, because this is the one I remember as a resident hearing about what you can do and what you can't do with patients who have HSV infection. I'm going to show you some of the data on that. But before we get started on this, I want to share with you, I don't know if anybody had a chance to see this on the news this morning, but they were talking again about the Oscars. And if you remember, this is what happened last week, that it comes time for the Best Picture, and they're going to make the announcement of the Best Picture. And of course, they read off the wrong film. And so they said it was La La Land when it wasn't La La Land. And if you notice, and what they announced on the news this morning, it turns out it wasn't the accountants. So it really wasn't the accountants. It turns out that they determined the causes, and as you can see, Hollywood, California, in a stunning and unprecedented finish to the Oscars last night. Presenters Warren Beatty and Faye Dunaway had announced La La Land as winner of the Best Picture, but during the La La Land acceptance speech, everyone realized that Moonlight had in fact won. Guess who's to blame? It was Anesthesia. So if you're not familiar, they've determined that yes, it was Anesthesia's fault that they announced the wrong Oscar. And as proof of this, that they have used this before. Because if you go back just a short couple of months ago, you can see that the Falcons Super Bowl loss was blamed upon anesthesia. And when the quarterback was sitting there being interviewed, the quarterback of the Falcons, this was their response. It's like anesthesia intubated our esophagus, causing us to choke. After all, it's always anesthesia's fault. So we're going to go on, anyway, we're going to go on a little bit about viruses. So what is a virus? And this will help us understand why viruses are such a problem in healthcare, and specifically we're going to focus on obstetric anesthesia. So a virus just contains either DNA or RNA. So a virus is not capable of replicating itself. So I think that's one of the most important things. So the virus just has this small amount of genetic material. What has to happen for the virus to replicate, it has to invade a normal cell. So what happens is it invades a normal cell, gets into that cell, gets incorporated, and that's how it reproduces. So now you can see why viruses are so hard to fight, because it isn't outside floating around. It's within the normal cell, and that makes it very difficult to treat a virus given the fact that it is located within the normal cell. And what happened is, you can see we're really up to date because this was the virus of 2016. If you had to look in Time magazine where they're going to talk about what was virus for 2000, it really was the Zika virus. What do we know about the Zika virus? It's a mosquito-borne virus, and I think one of the most things that are important, you can see this is the same type of virus that affects the West Nile virus, the dengue, and the yellow fever virus. But the important thing is that it's only transmitted by one type of mosquito. So that's important to realize when we talk about mosquito-borne and its infection, to realize that it is only transmitted by this virus, by this type of mosquito, and I'm not even going to begin to try to pronounce it, but it is this one. After the infection, symptoms typically will develop within 2 to 7 days after a bite from the mosquito. And what are the symptoms? Patients will develop a rash, a fever, they have joint pain, they typically develop pink eye, myalgias, and headaches. All symptoms that you would see with a viral infection. Thank you, Dr. D'Angelo. Things to remember with Zika virus, there's a very high chance, or there's a greater chance that the patient will develop Guillain-Barré later in life, and it can be diagnosed. So one of the things now, we do have laboratory tests for the diagnosis of Zika virus, and they're looking for the RNA of the Zika virus within the blood or the urine, and that's the name of the test. And it's important to realize this is not FDA approved. So I am talking about a non-FDA approved test, but to realize it's just for the diagnosis of Zika virus. And this just shows you right now there are 2 tests that are out there that you can test an individual for Zika virus. It's either looking at the immunoglobulin M or looking for this reverse transcription polymerase. And the importance behind this is that you can see when these things got developed, that it is fairly recent. So remember, Zika virus came to the forefront January of 2016. By February, we had a test that we can use for the diagnosis and a subsequent. And because these tests, and the feeling was it had to come quickly to the public, it has not undergone the strict testing that would be required to get it FDA approved. So the question next comes up, why should I worry about Zika virus? So remember, only 1 out of 5 patients who get infected by Zika virus will go on to develop symptoms. Remember, we already looked at those symptoms of the fever, rash, joint pain. Only 1 out of 5. The problem is that this virus does get transmitted from the pregnant woman to the fetus, and it has significant implications for the fetus in terms of microcephaly. So these kids, you can see here, when we look at these kids, with a normal kid, much smaller head with significant implications on that. So you can see, here we see typical head size, and these infants are born with microcephaly. When they did this, so now we're in January of 2016, the New England Journal of Medicine goes out and publishes the first case report on Zika virus. Remember, unheard of. Now we're in January of 2016. What did they notice? Well, when these kids with the microcephaly were born, if they did not survive, they did these postmortems, and the key is that they have this calcifications in the brain. It does not affect the brainstem. It is purely an effector on the brain, and that there's this microcalcifications with lysis of the cells. Why is this important? Well, we can see, again, we're in January of 2016, 11 infants were born with congenital Zika. Ultrasound prenatal, they showed that there was this brain damage, and then postnatal is all the things that we said, because remember, it doesn't affect the spinal cord, doesn't affect anything. It really just affects the brain. It's only within the brain with the higher. And there's the reduction in cerebral volume, ventriculomegaly, and this is now called the congenital Zika syndrome. So here's give you an idea of the transmission, so we'll have a look at it. So we have 125 women in Brazil who had the illness that was characteristic. So they had the rash, they had the fever, they had the joint pains. And they were felt to be infected, and they compared it to 61 pregnancies that did not. So we're talking a total of 186 patients. 125 had symptoms of it, 61 did not. Now we're going to look at the fetus. So these were pregnant women who had it. And the key is that you can see 47% developed symptoms of this versus 11%. The key is look at when it happens. So this is asymptomatic, symptomatic. So the light is asymptomatic, symptomatic. If you got that infection early in the pregnancy, you are more likely to develop complications than if you developed it later in pregnancy. We would have guessed this because remember, early in pregnancy is that period of organogenesis. This is the period of brain development. So it's no surprise that you see the effects. So Zika virus is bad, and just because you develop it later doesn't mean that you won't have an infant with this effect, but you do have a lower risk. So you can see here to give us an idea, adverse outcomes, 11%, 42% had abnormal brain imaging, and 4 with microcephaly. And the key is, even if you don't have the microcephaly, a significant number of them do have some abnormalities in the brain. Why is this such a concern? Well, because if you look at it, there was this huge spike in microcephaly. So one of the things is there's monitoring. They're monitoring these incidents of congenital anomalies, and all of a sudden we start to see a spike in microcephaly, hence the reason why the World Health Organization became involved. If we hadn't seen this spike, it wouldn't have happened. So they look at the births in U.S. from September to January with laboratory evidence of infection. And you can see we have 442 who had Zika virus, so these were documented. And you can see 395 live births with 21 of them having birth defects. So to give you an idea, it gives you an idea of the incidence. Just because you have the Zika infection doesn't mean you will have it, but you have a higher chance of developing this Zika syndrome. Higher chance of pregnancy loss, 47 pregnancy losses with 5 with birth defects, and 4 had the microcephaly, so 400. So you can see it's 1 out of 100, where normal cases, you can see 2 out of 10,000, very high, and the brain abnormalities. So now we get an idea of the problem that's this. So it doesn't mean you're guaranteed it, but you definitely have a higher chance of having an infant, and we definitely know that there's a greater chance if the infection develops early in pregnancy as compared to later in pregnancy. So here is now the most recent data. Go onto the website from the CDC to give you an idea of the Zika virus infections. So if you want, if you go to Alaska, Alaska is the only place now with 0. All the rest do have some form of Zika virus reported. So these were cases that have been documented by these laboratory tests. Give you an idea, you can see the overwhelming majority are due to travel in these infected areas. So travel-associated Zika virus is 4,700. So of these cases, you can see the overwhelming majority are because you traveled into an infected area. If you actually look at mosquito where they felt there was no travel, yet you had it, the majority come from Florida and 6 in Texas. So as of January, only 2 states reported Zika virus transmitted through the mosquito. Florida with the overwhelming majority, and if Florida, the overwhelming majority were coming from southern Florida, not from northern Florida, and the rest were all travel associated. There was 1 case of a laboratory acquired in which the person had blood, with a laboratory accident, had the blood injected in the skin, and they had it. And then you can see for sexually transmitted, there's been about 40 cases of sexually transmitted Zika virus. And that's where we stand in the United States. Why is this so important? Because the World Health Organization declared this an emergency. So this is important. If you look at the number of times the World Health Organization has declared an international concern, there's only been 3 previous to the Zika. One was the H1N1, then there was the polio in 2014, as well as Ebola. So this is only the 4th time that there's been a classification for international concern. And this is where we see that there's implications for public health and all these health beyond the states. Why is this important? Because the fact that it was declared a international concern, you're going to see we intervene much earlier than we had previously. So I'm going to show you how this had an effect. And in terms of blood management, in terms of screening blood products. So So what they did is they said, well, let's just use screening. So we're going to ask people, have you gone to an infected area? Well, the problem is you could see the majority of them are there, but you still miss donors that are sexually transmitted, and you miss donors such as what we saw in Florida and Texas where the mosquito, so it isn't that. So they said, well, let's try that. And the problem is it doesn't get everything. So now they said, listen, this is an area of national concern. So remember, Zika virus identified January 2016, August 2016, 8 months, they're now screening blood for it. Remember, any of those that travel, I saw Kenneth shared his age, I'm 54. Do you remember how long it took for blood to be screened for HIV? How many patients got HIV from blood that was not screened? Here, in 8 months, they started screening blood for this, and we'll get an idea. So again, because the fact that it got declared this international concern, they screened much earlier. 2016, November, you can see there were 40 that were tested, and they tested with the nucleic acid test. So 40 tested positive. So these were 40 potential infections that were prevented with this. And we have seen there was one case where a donor developed symptoms before, so this was where they were using screening. Let's see if we can go back, where they used screening, and you can see that this 2 patients got infected because of a positive transfusion related. This was in Brazil. So if you go, here's the CDC. They expanded blood screening in 2016 to all areas. As of 2016, 78 donations in continental U.S. and Hawaii, and 353 donations for Puerto Rico were prevented from entering the blood. So 78 in the continental U.S. tested positive for Zika. So they are screening blood products. And if you weren't aware, blood products in your institution are being screened for Zika virus. Here it is now from the University of Kentucky. And I went and just picked a picture, and you can see, screened for Zika, negative for Zika virus. So they do test blood for Zika virus. And they have picked up 78 in the continental U.S., as well as numerous ones in Puerto Rico, which are prevented from entering the blood donation product. So it's so important for us that transfusions are relatively safe for that. I think the most important thing is, since we know it is a bloodborne, it's universal precautions. You have to protect yourself from the Zika virus, and that's just by using universal precautions and avoiding it. And this becomes a particular concern in labor and delivery because there is the feeling that the virus may be in the amniotic fluid, and so we just have to adhere to standardized universal precautions. You can see this summarizes our Zika virus. Mother with Zika infection during pregnancy has a 6% chance of having congenital. To give you an idea, it is definitely higher than the overall incidence, but 6% will have it. Blood is screened for Zika. So when you go back and you hand your next unit of blood, take a look at it. You'll see on there it says screened for Zika, and they'll say the NAT, which stands for nucleic acid test. Remember, it's not FDA approved, but because it was an international concern, they were able to intervene much earlier. Go back and think about the HIV days. How long was it before they screened blood for HIV? Huge amount of time. And yet in this one, within 8 months, they started screening blood for Zika virus. I'm going to take a look at some of the herpes simplex virus, because I found this one fascinating. So who here has heard that doing spinal anesthesia, if the mother has herpes simplex 2 virus, and it is a primary lesion, spinal anesthesia should be avoided? So I'm seeing a couple hands go up, and where did that come from? Well, it's very interesting. So there's a lot of theory behind it. They say it's when you're primary, you have this chance of having viremia, and if you have the viremia, you can introduce the virus into the CSF. And they always quote this study to give you an idea. 169 patients over 6 years, 164 secondary, 5 primary. So Angela Bader did this. This is coming out of the Brigham and Women's, and we see we have 5 primary and 164 secondary. You can see majority of patients get, 59 patients got general, 75 patients spinal, and then we have 35 patients got an epidural. Where did this come from? Well, there was one patient who had primary. So remember, we only had 5. Of this 5, 1 got a spinal anesthetic, and of this 1, that patient had a transient neurologic deficit. Their legs were weak, but it went away. So I think the most important thing, there was a transient neurologic weakness that went away that was clearly not related to the herpes simplex 2 virus. And the thing they noticed that no patients, so of the 164 secondary, 5 primary, 1 had this. So the conclusion of this, spinal anesthesia is safe for secondary infection. Spinal anesthesia is relatively contraindicated in patients with primary infection. Wait a minute, it's an N of 1, and it really wasn't even related to that. So I think rather than saying it is absolutely contraindicated, we have to really say it's relative, if at all, because we really have no data to prove one way or another. I also don't have data to prove to you that it's safe, but I do have data, or we don't have any good data to show that it is unsafe, and you should use good judgment when you're doing this. To give you an idea of herpes simplex encephalitis, about 2 cases per 250,000 per year, and the overwhelming majority are due to herpes simplex 1. The overwhelming majority of herpes simplex 1 causes the encephalitis, not herpes simplex 2. where we sit there and we say it's contraindicated in this. I think that's an important with that. And if they do have it, there's significant morbidity associated with herpes simplex 1, which is why this study was so important. I have followed Dr. Vallejo's career throughout his. He's done incredible research. This study, I feel, is one of the most important and one of the biggest contributions I feel that he gave to the literature. It was the time period where people were unclear of the relationship between intrathecal morphine and herpes simplex 1. The reason that is, up until this point, what happened is Dermorph was released. So we have the intrathecal morphine being released. And because it was so new, you followed these patients so closely. I mean, they followed them so closely. And the only thing they found is, wow, these patients have a higher incidence of reactivation of oral herpes, herpes simplex labialis. So they said, well, we're not sure. Dr. Vallejo and his group confirmed it. In a very nice and elegant study, they took patients who had a history of herpes simplex labialis. They obtained the blood for herpes simplex immunoglobulin. In group 1, they got intrathecal morphine. In group 2, got IV morphine. What else was cool about this study? They also swabbed the area to see if the virus was located in the area. So we definitely know none of them had it at the time period which the intrathecal morphine was given. But the key was that when you looked at this, take a look at the people who had intrathecal morphine, you can see they had a much higher recurrence. So here's your intrathecal morphine. And I think the important behind this, the herpes simplex recurrence was much higher. So here we can see the herpes simplex virus was much higher. So what do we learn from this study? We learned that intrathecal morphine has a higher chance of reactivation of herpes simplex labialis. So important. Doesn't mean that if you don't get it, it's 0. You can see it's still there, but it's definitely much higher if you get intrathecal morphine. And they postulated, it's unclear whether it's the morphine affecting or the fact that it makes itching. It's unclear what causes it, but the only thing I can safely say is that intrathecal morphine increases the chance of reactivation. Why is that so important? Well, look at this case report in 2014. What is postulated in their final conclusion to their paper finally came true. 37-year-old G2P1 who has a past medical history of oral herpes with recurrence twice a year, elective repeat cesarean section, spinal anesthesia with bupivacaine, fentanyl, and morphine. So they did get the intrathecal morphine. We're now going to look at post-op day number 3. Mom starts to develop oral lesions. Post-op day number 5, baby now has oral lesions. So this is the first case report that I could find that documented of maternal transmission afterwards. So we definitely know it's bad. Look, 2 weeks of IV oral acyclovir followed by 6 months of oral acyclovir. Why is that? Go back. Remember, herpes encephalitis. Who's most likely to get it? Oh yeah, by the way, 90% of the cases are due to herpes simplex 1. Not herpes simplex 2, herpes simplex 1. So to give you an idea, neonatal HSV incidence 10 out of 100,000 causes significant death and neurodevelopment disability. And so I think one of the things that was pretty cool about this case report, which I haven't done, but you know what? I have started since I read this case report, just asking, do you have a history of HSV? And then to think about, does Dermorph play a role in that? And I think then I have avoided Dermorph in certain patients that have had this lesion. Do all patients have it? That's the problem with the case report. There are numerous patients who have gotten intrathecal morphine that this hasn't happened. However, we do know that intrathecal morphine can increase the chance of reactivation, right? And we know it's bad if it does get transmitted to the neonate. So if that's the case and you do have a viable option besides intrathecal morphine, maybe we should consider it. And that's how my practice has changed based on that data as well as this case report when you put the two together. So when we talk about this, I think there is a concern with spinal anesthesia with HSV2. I think people talk about it realizing there's no data to support it. There was one case report, or there's one series, 5 patients. One patient got the spinal. One patient had primary herpes, and that person had some leg weakness. Unclear whether there was a link between that, and it didn't seem to be. Intrathecal morphine, you can see increases the chance of HSV, herpes labialis reinfection, and you can see there is a case report. There's only one, but a case report of transmission from mother to the neonate. In my last 6 minutes, I'm going to touch on HIV. I'm going to go through this a little bit quicker because I don't want to keep you guys here late. But you can see HIV is definitely on the rise again. You can see 40,000 diagnosed. And I think the key for women, the majority are due to heterosexual contact. So when we look at women, 86% were due to heterosexual contact, only 14% due to IV drug use. I think the key to this is that when you look at the mother to child, it's unclear when, whether it's at the time of delivery or a little bit before, it can occur during breastfeeding, but we generally know the transmission from the mother to the fetus occurs late. Hence the reason ACOG recommends that all pregnant women should be screened. And in fact, if you're a high risk patient, they say not only should you be screened early in pregnancy, but you should be screened again later in pregnancy, because there's several things that can be done. I'm old enough to remember when AZT first came out, pretty significant, and then they investigated AZT for pregnancy monotherapy. Absolutely amazing, absolutely amazing. It took 25% and dropped it to 8%. Wow, for somebody that had lived through watching all these patients die from HIV, to hear that AZT, perinatal AZT, could drop it from 25 to 8%, absolutely amazing to me. Now we're not just using monotherapy, everything is this combined therapy, and you can see it can drop it down to 1.2%. And these are the various combos that are used for the combo therapy. So what else do we know? We know cesarean section, because generally there's something in the labor process or the delivery process that can cause it. Hence the reason C-section also decreases it. So for that reason, those that are old enough will remember that patients who are HIV were all getting C-sections, because we know that it decreased transmission. Then we took a look and we said, does it drop it any lower than if they already are taking the retrovirals? And that was the thing. So C-sections are still done for women who come in who haven't had the therapy throughout pregnancy, because if they haven't, that'll decrease it from 25 to 8%. However, if they're getting the antiretroviral therapy, you can see that it doesn't add any benefit to it. So whether it's a C-section or a vaginal delivery, if the viral load is low, there's no increased risk of transmission. I think the key is HIV does not increase the chance of preeclampsia, but this antiretroviral therapy does. That if you look at this, that one of the recurring themes of these patients that take these medications before are more likely to become preeclamptic, and we need to remember that. This has led to this PrEP. So this concern that women are taking the medications, these antiretroviral therapy, even though they're not HIV positive, but they're in a high risk, or they're maybe with a partner who does have HIV, to prevent this. And so what we're seeing is these women are coming in, taking these agents even though they have not. And what they're doing it is they might be taking it pre-conception. So we're starting to see this before. And this huge meta-analysis of 19,000 mother-infant pairs who were on this antiretroviral therapy before conception, you can see increases the risk of preterm, increases the risk of low birth weight, but it did not increase congenital anomalies. So we are starting to see these women come in on this PrEP therapy, and it's generally this combined tenofovir with this medication, and it does reduce infection. Give you an idea, the cost is $1,400 per month, and Medicaid nor Medicare pays for this. So if you're using it for PrEP pre-exposure, it's about $1,400 per month, and Medicaid does not pay for it. What are the implications for the anesthesia provider? Well, we still see about 1 out of 8 are HIV infected and might not know they're infected. Hence the reason why the majority are occurring with sexual contact. More at-risk patients are starting to get this ART prophylaxis. So they're coming in on these medications before, so we need to be aware of it, realizing it doesn't increase the risk of congenital anomalies, but it does increase the risk of preterm delivery. The current recommendation is triple therapy. So if a woman comes in and she's diagnosed, she will be gone on triple therapy before. And in that case, that lowers the chance of transmission to 2%, and that is then recommend no greater with a C-section or vaginal delivery. They will check a viral load before the time of delivery to see, and if the viral load is low, they'll let her do a vaginal delivery. Again, a big change in practice. The ART, this antiretroviral therapy, is linked to preeclampsia and preterm delivery, and we already said the C-section depends on viral load. So with that, we've had a chance to go through a couple of the viruses that we see. Zika, I think, is absolutely amazing. We went from just the diagnosis in a little over a year ago to where all blood products are now screened. And again, it was because the intervention of the World Health Organization. And as we saw, 400 donors who would have been contributing blood and adding it to the blood products that are available in the United States have been removed because they've tested positive for Zika. I think the things as a provider, you need to realize you need to practice universal precautions, and that's to prevent you from infection with Zika as well as HIV. Herpes simplex 2, you hear people say spinal anesthesia is to be avoided because of the fact that there's the risk of infection. Realize it comes from that one case series. It's not even a study, it's a case series where there was this neurologic deficit that was not related to the virus. However, it did conclude that, and I don't think we have enough data to conclude that it's safe, but we also don't have enough data to conclude it's unsafe. Use good judgment when deciding what type of anesthetic. I think one of the things that we saw that both IV and intrathecal morphine can activate herpes simplex labialis, but it's definitely higher with intrathecal morphine, and now we have a case report where the mother transmitted it to the neonate, and it was probably linked. We definitely know it's a higher chance, and she did get intrathecal morphine. Hence the reason, one of the things that I always include in my preoperative history, do you have a history of herpes simplex labialis? And then I make my decision, does the benefit outweigh the risk? But you should include that in your preoperative history. And with that, we've had a chance to take a look at viruses as we go through, and as we can see here, as the woman, when they're going by, oh, I don't feel so good, and the guy's walking his virus, bad, right? Ha-ha. Anyway, with that, I'll conclude, and I'm going to turn it over while Dr. Scavone comes up. Thank you very much.